Professor Emeritus, Department of Shalatantra, SDMC Udupi, to take for the session. Welcome, sir.
Now, the next part is about the clinical examination of the neurological system. There is a very popular statement which says that history tells you what it is and the examination tells you where it is, and it's a very specific for the nervous system examination. A detailed history gives you an idea like what sort of the pathology it is, and a thorough clinical examination is necessary, and most of the times, majority of the conditions, the exact location of the disease may be possible with the methodical clinical examination. Now, clinical examination of the nervous system is a bit different from the other systems because it has a very detailed approach. The approach is slightly different, and the primary approach of the examination of the nervous system would be under these heads like higher functions, cranial nerves, sensory system, motor system, reflexes, cerebral science or cerebellum or cerebellar science, meninges, and then there is a system survey. These are the steps in which we will discuss about the neurological examination as such. Among the higher functions, the first of that, the points which you have to note are the gait, the speech pattern, memory, orientation, intelligence, and psychological disturbances. The gait or walking is one of the very complex maneuvers where it needs coordination of different sets of the areas of the central nervous system as well as the peripheral nervous system. And normal gait would have what we call as a normal gait cycle. The normal gait cycle starts with the support of the two legs where both the legs are in contact with the floor. Then there is the next stage is a single support stage where one leg is raised up and then the other leg is raised, one leg is raised up and the other leg is having the support, and during this phase there will be a gradual progression of the legs, or the one leg from the hind part to the front part. This is what we call as the mid stance and terminal stance. Terminal stance is that position in which the legs would move forwards, and during this phase the person would be standing on a single leg support. Then there is another phase of the double support, and then there would be another forward movement where the weight is changed or the side is changed and the other leg goes to the same, and hence there would be another swing action where the leg would be kept forward. So one step cycle would be having these much of the stages, and there again they could be classified into stance phase and swing phase. Now that's about the analysis of the gait as such. Now the whole normal gait requires coordination of many areas. The most important is the weight bearing mechanism of the balancing mechanism of the body controlled by vestibulocochlear, visual input to the optic nerve, then the muscles which need to be coordinated, and the muscles almost throughout the body, both the upper limb and the lower limb muscles, they need to be controlled, and hence a proper assessment of the gait can often give you a clear idea about the nature of the pathology. From your classical textual point of view, there are many special names given to the gait abnormality. Now, many times these names are a bit confusing, like the complex names are there, they can be confusing, and a proper observation is necessary. That I think that names are not important, but the abnormality has to be noted by which you can make out. Now, among those popular names which are often used in the text, like the hemiparetic gait. The hemiparetic gait is a situation where the one arm is bent and it may not have moved, and the patient tends to walk on the tip of the legs as such, and patient tends to bend towards the opposite side, whereas one side it may have the normal stance, normal appearance. That's what we call as a hemiparetic gait. Then the one part would not move properly, there would be rigidity. Then there is another called type as the ataxic gait. Ataxic gait, again there could be of two sorts of ataxia, the motor ataxia and the sensory ataxia. Motor ataxia, where the patient may have a difficulty in maintenance of the balance, and hence the patient keeps the legs quite apart. The gap between the two foot would be more, and the patient may not be able to sustain the weight in the erect posture. There is a tendency to fall down or bend forwards or bend backwards, right? That's typical of motor ataxia, which is a sign of extrapyramidal tract involvement. There is an abnormality of the extrapyramidal tract. A person who may have a sensory ataxia, as in case of the peripheral neuropathies, where the person may not be able to sense the areas properly, in that condition, there is also an ataxia where the patient may have an instability, but that instability is presented as a much raising of the foot. See, during walking, usually we will raise the foot to a certain extent, but in the persons who have a sensory ataxia, the foot which is raised would be quite high, and it looks like the person who is trampling, like jumping, like action would be seen, not the normal gait as such. That's the ataxic gait. Then there is a shuffling gait. So the shuffling gait again is seen in case of the extrapyramidal tract pathology, particularly the Parkinson's conditions, like where the extrapyramidal tract is involved. It's characterized by the tremors and bending forwards. The person would be bending forwards as such. The footsteps taken would not be rhythmic. There will be shuffling, like once this foot and then the other foot, and may not be that regular cyclical movement would not be seen. And as the patient moves, the time taken for the movement would be reduced gradually, and hence it looks as if he is accelerating. The patient is speeding up as such. That kind of an appearance is seen, and that's what we call as a shuffling gait. Then there is a steppage gait. Steppage gait, particularly in the patients who have foot drop side, foot drop where the motor as well as maybe the sensory structures to the foot are affected, or maybe in the spinal cord there could be stenosis, like the motor functions are lost as such. In such conditions, the foot would not be raised up, it tends to just be pulled on the floor. So the over the floor, the toe would be now just grabbed, like that kind of an appearance is the steppage gait term used as such. Then spastic or seizure gait. Spastic or seizure gait also is a sign of the hemiparesis-like condition. But in the later stages, hemiparetic condition where there is a spasticity, as the patient moves, the normal side of the leg would be moving straight, whereas the affected side would not have a straight movement. Instead, it looks like a circular, something passing through a circular path, and it looks as if that leg is crossing over the other side, and that's why it's called as the seizure gait or a spastic gait, which is seen in case of the hemiparesis conditions. In the spastic hemiparesis, patients who have reached that spastic stage. Another common name used is entalgic gait. The entalgic gait means whenever there is a painful condition, there would be a spasm of the muscles. Spasm of the muscles, the purpose is to reduce the movement over the area where there is pain. See, when the pain will be aggravated when there is a movement, and the spasm of the muscles on the opposite side of the pain would be producing a deviation, and this is what we call entalgic gait. It's not necessary that the term entalgic gait is given only for the spinal cord pathologies, but very often we use the term entalgic gait for the patients who have a painful pathology in the vertebral column, and hence the paraspinal muscles will be under spasm, and hence the patient will be bending to a side, as occurs in case of the disc lesions. But the term entalgic gait also attributed to any other abnormal movement due to the spasm of the muscles elsewhere. It's not necessarily limited to the vertebral column pathology, though popularly or commonly it's limited to in the vertebral column painful entalgic gait conditions. The body would not be straight. If you draw a midline straight line, the body looks like bent towards the side of the lesion. Spasm of the muscles will be producing that kind of deviation. That's about certain common varieties of the gait abnormality. The next part is about the assessment of the speech. Now, assessment of the speech also would be a very detailed one. Again, I will not go into all the details, right? But and it's also a bit complex issue also. To locate the abnormality, you need to have a primary approach. That a easy approach would be, the first thing is whether the patient can speak fluently or not. The three things which you have to observe is fluency, comprehension, whether the person can understand what he is speaking, like whether it's relevant or not. The other part is whether the person is repeating whatever he has said, like it's not that it's not a free speech as such. Now there is a general plan of action, a simple diagrammatic issue which is given. As such, if you for all these three questions, if you have an answer yes or no, then you may come to that varieties of the abnormal speech. A person who cannot speak, not comprehend, and not even repeat whatever he has told, like a word which is repeated, then that's what we call as a global aphasia. Global aphasia, where the person cannot receive the sound as well as person cannot react to the words or react verbally. That's the situation which we consider as a the global aphasia, where every part of the brain has been affected. Then if the person is able to speak fluently and he is also able to understand, but he is not able to repeat the words which are produced sound, which we call as a transcortical aphasia, where there is an abnormality across the cortex as such. If a person is not able to speak fluently, but he can understand properly, and again he is not able to repeat the sounds, repeat the word which is pronounced, this is at the Broca's area. Broca's area and its relation to the speech formation we will discuss later on. To understand that, the basic issue is whenever you have to speak, there should be three components. One is there has to be a stimulus which requires the speech, and that stimulus has to be understood. It could be stimulus, could be anything, like somebody has asked a question or something of that sort, where there is a need for speech, that has to be understood. And then there is an area of the brain which integrates, which thinks about like what should be the response, what should be the speech, and then there is an execution. The word has to be executed, and the specified muscles need to be stimulated, and then of course the speech has to be produced by the speech organs, the larynx, vocal cords. They need to contract and allow the words to be produced. So now that's about the main three steps as such. Now Broca's area is the one which produces that word reaction, the as such, and hence if a person is not able to repeat the word and he is not able to give an answer fluently, speak fluently, but he can understand, then that's called as the Broca's aphasia. The patient can understand but he is not fluent in speech. That's called as a transcortical, where the muscles which are related to the speech are not contracting as such, are not producing the sounds as such. Now, if a person is able to have a fluency and can comprehend, and then of course he also can repeat occasionally, but still he doesn't speak properly, that's called as anomic aphasia, which is usually in psychological conditions where there would be no structural pathology, it could be only functional pathology. If a person is able to comprehend, can speak fluently and also can understand, but he is not able to repeat, then that's called as conduction aphasia, where there is an abnormality of the conduction of the impulses from the integrative area to the speech forming area. Similarly, there is a transcortical aphasia, sensory aphasia, where the person is not able to sense the sounds, so comprehend, he is not able to comprehend, can speak fluently and also can repeat the words, then that's the transcortical, where the sensation is affected. Wernicke's aphasia is when the patient is able to speak fluently, but it's not able to, he is speaking irrelevantly, and he is not able to repeat the word which is uttered. That's the vernix aphasia, which often also is related to psychiatric conditions, which we generally see in case of the psychiatric conditions. Anyway, so in a patient presents with a speech abnormality, it's essential that you have to point out, assess the type of the abnormality of the speech, and it's true for both aphasias and dysphasias. Dysphasias where the patient may have a difficulty in speech or maybe a irrelevant speech as such. So that's about in brief, a very brief idea of the assessing the aphasia as such. Of course, there can be more detail about that. Then comes the assessment of the memory. In the memory test, usually it is done by a simple questions about the recent incident and the past incidents. So we need to assess the recent memory as well as the past memories separately. A loss of recent memory, abnormal recent memory suggests about maybe a cortical lesions at the cerebral cortex, any sort of lesion. Again, it doesn't specify which type of the lesion. Whereas a person who has an entire remote memory but recent memory is intact, it's a subcortical lesions. Again, which of the areas and which type of the memory loss we will be discussing later on in detail when we go into the neurological diseases with the impaired memory type as such. So for the present, I'll limit only to that, cortical and subcortical. And the subcortical varieties, we will come to that part when we go into the discussion later on. Then orientation of time, place and person is the next part which has to be examined, and this can be done by simple questions like the time of the day and the location where the person is, or maybe whether he can identify a person or not. Intelligence is can be assessed by simple questions which require some thought process, like maybe a calculating, adding a few numbers or so on. It could be relevant as per the educational background of the patient, so on. So some simple questions like asking 1 plus 2, how much is it, or so on, or it may be related to occupation and so on, that also can be done. And then psychological disturbances, whether the patient has any illusions or hallucinations. Illusions are a patient may feel that there is something around him and feeling like whether he is in a situation where the real situations are not properly understood. He may have a feeling that somebody is harming him or somebody, so on as such. Hallucinations are where there is something totally unseen or non-existing situations which are felt by the person. He may feel that there is some demon or so on. So these are the issues which need to be assessed. That's about the primary assessment as such. The next part of the clinical examination is the examination of the cranial nerves. So first part is about the cortical activity or the orientation as such. The next is about the cranial nerve. Among the cranial nerves, the first nerve is the sensory nerve, olfactory nerve, which receives the smell. And the usual protocol of examination of the olfactory nerve is you have to close the eyes and you have to have some substance which would produce a smell, and the patient should be familiar with that smell earlier. Any smelling substance could be used. Need not be a pleasant smell or foul smell, that doesn't make much difference. Important is the visual input has to be avoided, so patient has to keep the eyes closed, and maybe you may have to examine the smell sensation in each nostril separately by keeping the substance. It could be any substance which the smell of which the patient can identify is familiar. Of course, if there is a abnormality of the smell perception, the abnormality could be either at the receptor area, or it could be at the conducting area, or at the higher center. Now, whether it is in the receptor area, or whether it is in the conducting area, or whether it is in the higher area, that has to be differentiated based upon the other findings as such. If a person has a abnormality of the nasal mucosa, as in cold-like conditions, it could be only the sensory abnormality where the sensory nerve endings may be either not getting stimulated to the stimulus as such, and in that condition there would be no other findings except that loss of sensation. If there is an abnormality of the higher centers of reception, there would be some other findings which are related to the central nervous system, and hence the ultimate interpretation, like whether it is in the conducting, receiving nerve endings, or whether it is in the nuclei in the higher center, that has to be finalized based upon the observations of the other findings. So, but these findings of each cranial nerve observations, they have to be put in, noted down properly, and at the end you have to integrate all the findings and then come to the conclusion like where the lesion is. So single test doesn't confirm the origin of the lesion. Similarly with the optic nerve which is responsible for the vision, proper vision, it could be, the examination should be of mainly 4 categories. Assessing the acuity of the vision. Acuity of the vision is whether the patient can read or observe the substances as any other person, normal range. And to assess that, usually you will use a Snellen chart where you will have some alphabets written over there or the numbers written over there. Or it could be simply by kept asking the patient to identify some object based upon its size, maybe a smaller object or a bigger object, and see from which distance he can identify. This also is possible if a person is illiterate, cannot read, then Snellen's chart would be of no use. In the Snellen's chart, you will have the fonts of a defined size, and the standard distance in which a person, normal person, would be able to read is mentioned. It's usually kept at 6 meters distance, and then you will have the vision which is often named as 6 by 6 in the sense if a standard size of the font which otherwise would be read at 6 meters, and the person also can be reading that same at 6 meters distance, then you will be noting it as a 6 by 6. That's a normal. 6 by 6 is considered as a normal in the standardized Snellen chart. Now, depending upon the other way, like suppose a person is not able to read the font which is supposed to be read at 6 meters distance, but he is able to read only at the at keeping at 6 meters distance. He can read only the letters which otherwise would be read at 12 meters distance. Then you will note that 6 by 12 and so on. So that suggests about the acuity of the vision. Of course, with the computerized instruments now, where the vision can be assessed, acuity can be assessed without that visible chart, you get the numbers accurately, maybe more accurately with that. Then the next is about the visual field. The visual field is the width of the area which one eye can see. So it is used by either a perimetry instrument, or if you do not have a perimetry instrument, it can be done with the keeping the patient's one eye closed. One eye has to be closed, and then the person who has examined should be kept at arm's distance from the patient, and then he has to move the finger across area and see whether the person can see, the patient can see the range of movements beyond that in a horizontal movement, the range in which the person can see the fingers without moving the eyeball. That's the important thing. The eyeball should be kept steady. So you ask the patient to look at your eyes constantly without moving the eyeball. Only move the finger and see whether the range of the distance which the person can see. And you will be comparing that to your visual field. That's a course method of assessing the visual field. If you have a perimetry, the instrument where you will have a knob moved around as such, that can be made out easily. Then the color is the next part. Again, color charts are usually used, like where a Ishihara chart, you will have that typical chart where a person with a color blindness would be reading a different number, and a person with normal color vision would be seeing a different number. The color dots are arranged in such a way that, or it could be by simple question like whether the person can identify a green object as green or a red object as a red, or so on. So that's how it can be done. It also can be done with making use of any object which has multiple color. Fundoscopy is another of the option which is used for optic nerve assessment. where the structural aspects of the optic nerve fundus also can be studied as. The next nerve which we study would be the oculomotor nerve, the third nerve, which is motor, primarily motor nerve, and mainly it's to study the eyeball movements. The eyeball movements are studied, and that the standard test protocol is called as Cover's test, where the person is asked to move the eyes around and look at the position of the eye. See, when a person is asked to move at an object which is away from the one side, and the position of the pupils. Now, see, if one pupil is a normal pupil, of course, this is a normal pupil and abnormal pupil, equality so. And when the person is moving around, the normal pupil will be normal eyeball, sorry, not pupil, normal eyeball will be moving in the direction of the object, whereas the affected eyeball may move in a different direction. And based upon that, the abnormalities of the movement are classified as exotropia, esotropia, hypertropia, or hypotropia. Again, these words are a bit complex. There is nothing special about it. It's only that when the when a normal eyeball moves laterally, if the affected eyeball moves medially, then it's called as a exotropia. If the when a person is asked to look towards the nose, if the eyeball moves towards the temporal side laterally, that's called as esotropia. Now, these pictures would define that as such. Then when the eyeballs move when you are looking upwards, if that eyeball moves downwards, the affected eyeball moves downwards, when you are attempting to look upwards, that is called as hypertropia. Or if there is a upward movement when you attempt to look downwards, that's called as a hypotropia. Now, these are the names which it suggests about which arm or which wing of the oculomotor muscles would be affected, and it can help in localizing the pathology. So, and particularly this can make out like whether the pathology is peripheral or central. In a peripheral, it could be any of one of the lesion, whereas in central pathology, it could be all exotropia or two hypotropia. All that lesions could be seen. Then comes the trochlear nerve. Of course, trochlear nerve also is a motor nerve which also connects to the eyeball movements, related to eyeball movements, but it's only for the superior oblique muscle. So, clinical examination would be almost the same as that of the oculomotor nerve. In the same, you will be seeing that. Then again, the same, it will be hypotropia which can be seen in case of the trochlear nerve, a normal gaze and a typical gaze in a oculomotor nerve. Normal gaze, when you look straight, both the eyeballs would be at the same position. But when you try to look at another downwards, when you look downwards, the eyeball on the affected side will be moving extremely downwards, and the patient may have a symptom of double vision, and that double vision which is not constant, and the double vision becomes more when the person is attempting to look at both the sides, left and right side. If you at all you ask the patient to look at both the objects, like to keep the two fingers away, and if the patient says that there is a double vision, that also could be a sign of involvement of the trochlear nerve. So it could be by taking the history about the double vision, or object is assessing that eyeball movements clinically. Then is the trigeminal nerve. Trigeminal nerve is primarily sensor, but at the same time there is a motor component too, and it has mainly the three roots: ophthalmic, maxillary, and mandibular. And the main examination would be assessing the sensations over these areas, over the ophthalmic area, or the maxillary area, or mandibular area, by which you can make out which component of the trigeminal nerve is assessed. At the same time, it also can be related to the tongue movement as well as the feeling of the taste of the mouth. Tongue movement, if the tongue is shifted to one side, that also can suggest about the involvement of the motor component of the trigeminal area. So, trigeminal area examination would be primarily sensory examination of the face, and these different zones have to be assessed. Sensory examination is by primary touch sensation, and it also can be assessing by the corneal reflexes. So touching the eyeballs, the eyeball reflexes also are a part of the same. Then the abducens nerve is again it helps in the eyeball movements help as such, but the whole of the eyeball moves on that, and most of the time the patient would have a double vision when the patient looks at a horizontal distance, horizontal way directly. It also helps in reduction of the visual field, impairment of the visual field. So when the method is the same as that of the assessment of the visual field, you keep the distance, examine the patient and the doctor will be keeping a distance of 2 arms length, and the patient is asked to look at the finger of the doctor, and the doctor would be moving the finger away and medially, and during this, if the patient has a diplopia, double vision like feature, and the eyeball movements otherwise are normal, then that's considered as an abnormality of the abducens area. Then facial nerve is primarily motor nerve. Primarily motor nerve. Of course, there is a sensory component too, and the examination is by assessing the movements of the facial muscles, and the facial muscle movement at different level. It's important, like if the, and again the important is in the facial nerve pathway. Majority of the lesions which we see as the facial palsy would occur at the lower motor area beyond the facial canal. Some of the lesions could be in the central area, which is also called as upper motor, where the lesion is in the intracranial area. More detail about the disease conditions which can produce this upper motor and lower motor, we will come to that when we discuss about the disease of facial palsy. But now it's only about locating the lesion. If the patient has a pathology lesion and the distribution of that would be, there would be a decussation of the nerve fibers across from this facial area, and the nerves, particularly the frontal nerves which are supplying to the frontal area, they would not be passing through the facial canal, they would be outside the facial canal, and hence this study is important. If the patient has a lower motor neuron pathology, that's if the lesion is on the lower side, external side, then if you ask the patient to close the eyes, the patient would not be able to close the eyes on the affected side, and the face would be deviated to the affected side. And if you attempt to close the eyes, if there is a lines of the forehead, like forehead is wrinkled, that wrinkling of the forehead, that suggests that it could be an upper motor area or central pathology. If the wrinkles do not occur, that's suggestive of the lower motor pathology. This is how facial nerve is examined. Then the vestibulocochlear nerve, it has mainly 2 components. The vestibular component which helps in hearing as such, intensity of the hearing, and the cochlear is for the maintenance of the position of the body. From the clinical examination, both of these have to be assessed, and for that the examination would be of 2 components. The one is about the hearing capacity, whether the person can hear properly or not, and whether the bone conduction and the nerve conduction are proper or not. And this is done by the Rinnes test, where a tuning fork is used and kept on the mastoid bone until the patient is able to hear the sound. It is kept on the mastoid bone. Then immediately it's changed, the position is changed, and it's brought towards the front of the ear. And if the patient, in a normal person, air conduction is always better than bone conduction. So even after that bone conduction ends, you will be able to hear the sounds. If the patient is not able to hear the sounds after that bone conduction is over, that suggests that there is an abnormality of the air conduction. So the cochlear component, the receiver, would be lesser. Similarly, if at all there is any doubt about which side of the ear is abnormal, Weber's test is done, where the tuning fork is kept on the midline over the skull, and you see which side is heard better. Then as far as the cochlear, and now of course you have a audiometry instrument, a computerized audiometry instrument, where this hearing and its records or reactions can be recorded graphically, and hence that's much better than the Rinnes or Weber's test as such. So audiometry instrument, if at all you have that instrument, that would be a better option than simply a tuning fork test as well. Then as far as the cochlear component is concerned, the basic test would be, the first is whether the person can maintain the position against the gravity or not. That's Romberg's test. Romberg's test is done by asking the patient to keep the foot close together and stand straight, then close the eyes. Once the visual input is stopped, if the patient has an abnormal cochlear functions, he is not able to maintain the position against the gravity. A cochlear functions would be that the tubules over the area would be helping in maintenance of the position against the gravity by the giving input even when there is no visual input. So if you block the visual input and if the patient is not able to maintain the position against gravity, that's a sign of the abnormality of the apparatus there. Then comes the other coordination test. The coordination also is a part of the functions of both the same, the vestibulocochlear apparatus, and vestibular component has that functions there. And in that situation, the test is done by having the patient to coordinate certain issues, areas. Simple test which is commonly done, standard test is a pass pointing and finger nose. Pass pointing is the patient is asked to touch the finger of the physician. If the movement is smooth and he is accurately touching that, that's a sign that the vestibular cochlear functions are normal. And similarly, asking patient to touch the nose. The same also are considered as the coordination test, which will help in assessing the complex maneuvers of different coordination of the muscles. Then comes the glossopharyngeal nerve. The glossopharyngeal nerve is the mainly sensory area of the tongue, which receives the sensations of the taste, and usually the patient will present with the loss of sensation as such. It can be specifically done by touching the posterior surface of the tongue with a maybe soft palate also, with the touch sensation in the area, as well as whether the person can feel the taste at the posterior area or not, it also can be identified. Of course, glossopharyngeal nerve as well as vagus nerve, their examination of sensory component would be almost the same as such, and they are not separated as such. Vagus nerve, it has a motor component too, along with the sensory component of the tongue, and it also has a wider distribution into the cardiac as well as GAT. So clinical examination of vagus nerve is really incomplete always because of the cardiac component and the gastric or gastrointestinal tract components that cannot be assessed simply by clinical examination. But the motor component is assessed by the pharyngeal gag reflex. That's by touching the posterior pharynx, there will be a contraction of the muscles, and that's how it is done. In a patient with a particularly recurrent laryngeal nerve branch of the vagus nerve, if it is affected, the motor reflex or the gag reflex will be affected. If you touch the posterior surface of the palate, there will be no contraction, reflex contraction as such. So that's how the vagus nerve is examined, particularly the motor component. The other autonomic component of vagus nerve, it cannot be assessed by a simple clinical test, which requires some more of the investigations. And when we discuss about the autonomic nervous system, we will be discussing more about the assessment of the autonomic functions of the vagus nerve. Then the spinal accessory nerve is mainly the motor muscle for the muscles of the neck and shoulder, and the usual test is done by making the arms contract and looking at the position of the trapezius muscle and the this shoulder blade or scapula. Normal scapula would not be winging. A patient with hypoglossal spinal accessory nerve abnormality may have a winging of the scapula. The position of the scapula would be changing depending upon the intensity of the damage to the muscle, the neuromuscular junction and the palsy. There will be a palsy of this. Patient would not be able to either range of the movement of the shoulder could be affected, and moreover the position of the scapular blade is one of the important criteria during the movement of the shoulder. Then the hypoglossal nerve primarily is about the movement of the tongue, and when you ask the patient to stretch the tongue or extend the tongue, instead of coming straight, it may be deviated to a side of the lesion, and that's the confirmatory of the hypoglossal nerve. Now, this is in brief about the examination of the cranial nerves. Now, the next is about the sensory examination, somatic sensory examination. Somatic sensory examination is again of two categories. Sensations are primarily categorized into two categories, non-cortical as well as cortical sensory system. Now, that's meaning by, what we mean by that, ultimately the sensation which is received at the cortex of the brain, and which also are called as a relative deeper sensations, they are the cortical sensory system. Acute sensations, where the person would produce an immediate sensation, would be the non-cortical sensation, which is called, which are light touch, feel, heat, cold, heat and cold. Vibration sensations are categorized non-cortical sensories, whereas the cortical sensories are like the kinesthetic sensation or position in the space, size and shape of the object, or tactile sensations. That's when you make a pattern over the skin surface, it's felt. It's also called as graphesthesia, or point of discrimination sensations as such. The tests are done for the light touch with a cotton swab. You touch over the surface of the body, see whether the person can feel the sensation or not. Ideally, it has to be done with the eyes closed, so visual input as always has to be avoided, and you have to start from a apparently normal area to the abnormal area. So initially, you will have to see whether the patient can feel the sensation normally or not in a apparently normal area, and then come to the area of the abnormality. Pain felt is sensation is felt by a pricking needle as such, but pricking should not be harming the tissue, but it's just moderate pricking with a pointed instrument is how you feel the pain sensation. Again, in the same manner, the visual input has to be closed, and you have to start from apparently normal area to the abnormal area. Heat and cold also can be examined by test tubes containing these hot and cold water. Vibration sensation is felt with a tuning fork in the same pattern, like eyes are closed, and then they are we start from apparently normal to the abnormal area. Then cortical sensory system, like the kinesthetic sensation is done by either flexing and or extending any of the joint, and then asking like whether the patient can feel that or not. Again, the same protocol, eyes have to be closed, then you have to flex a joint and then ask the patient like whether the joint is flexed or extended, and the patient should be answering correctly. Size and shape of the objects, again eyes are closed, and then give some object which is which the patient is familiar, and whether the patient can feel that or not, any cuboid or maybe long, elongated or so on. Then the tactile sensations or graphesthesia is done by keeping the eyes closed on the patient, and then you maybe draw a pattern over the surface, maybe write a letter or write a number over the surface of the body with your finger, and ask whether the patient can feel that or not. Then 2-point discrimination is done by touching the 2 points over the area of the body, and whether the person can feel these 2 parts separately, 2 points of contact separately or not. The minimal distance discrimination would be 2 centimeters. If the point of stimulus are less than 2 centimeters, then the person may not be feeling that as 2 different points, otherwise it will be same. So that's how it has to be assessed. Then the next is about the assessment of the motor system. We will continue in the next session. Already the time is up, so we will continue that examination of the motor system in the next session as such, and we will wind up today. If there are any questions, we will try to answer. No, there are no questions, so we will wind up today. We will continue in the next session about the examination of the motor system. Right, okay, thank you.